Okay, so hi folks, my name is Eric Whelan. I'm a master's student in UCD and I've been working in DCU throughout the pandemic. And today I'm going to speak about loneliness during the pandemic. I'd just like to start by thanking the organisers for giving me the opportunity to present the research here today. The presentation is titled A Mixed Method Longitudinal Analysis of Loneliness in Ireland During the COVID-19 Pandemic. The findings I'm going to speak about come from the Adjusting to COVID-19 research project, which myself and Dr. Louise Hopper ran through the School of Psychology in DCU over the past 15 months. So just to outline how the presentation will flow, I'm going to introduce the timeline of events and how those events coincided with data collection. Even though we're all aware of the timeline, I think it can be really helpful to explicitly state what happened and when. I'll then describe the scope, purpose, and procedure of the project a little bit further before highlighting the quantitative findings from phase 1 and phase 2 of the project. There was a substantial quantitative element to the project, but we also captured some really good qualitative data. So I'd like to cover both and combine them where possible. So we all know the COVID-19 story at this stage. The World Health Organization declared the outbreak of pandemic on January 30th, 2020. The Irish government introduced the first lockdown on March 16th, 2020, and you can cast your mind back to the panic buying, the fear about how bad the virus could be, and the uncertainty about the future. Many of these have somewhat reduced at this point, but that initial fear was really prominent for a lot of people. The second lockdown was then introduced in Dublin on September 20th, 2020, and a month later, level 5, the most stringent lockdown measures were introduced for the rest of the country. Those measures remained in place until December 1st, when the country decided to let loose and save Christmas. But then the third lockdown, of course, was introduced on December 26th, as daily cases surpassed 8,000 in early January. And that lockdown remained in place for just under 5 months until May 7th, 2021, I should say. God, missed me a year there. So during the first and the third lockdown, Dr. Louise Hopper and I ran the Adjusting to COVID-19 project in DCU School of Psychology. In phase 1, we recruited 207 participants and collected data from each participant once per month between April and June 2020. So that's 3 data collection time points for phase 1. In phase 2, we repeated the procedure with 156 participants between February and May 2021. We measured mental health using the Patient Health Questionnaire 4, loneliness using the UCLA 3-item loneliness scale, and intolerance of uncertainty using the Intolerance of Uncertainty 12-item short form scale. So looking at the mental health findings first, a higher score in the PHQ-4 suggests greater prominence of potential mental health symptoms. Scores greater than 5 indicate moderate mental health symptoms, and in February 2021, looking at the graph on the left, we see the mean PHQ-4 score for people aged 18 to 29 was 5.6 in the sample, into that moderate category. So from phase 1 of the project, age, loneliness, and intolerance of uncertainty were identified as significant predictors of mental health between April and July of 2020, predicting between 30 and 45% of the variance in mental health scores. These findings were then replicated in phase 2. Interestingly, gender was also a significant predictor of mental health throughout phase 1, but the gender differences disappeared and actually inverted in phase 2, as we can see on the graph on the right. The male figure is actually higher than the female figure by April 2021. We're currently analysing the data to figure out whether this is an artifact of the change in samples between phase 1 and phase 2, or whether that difference actually disappeared. So far, we found that the phase 2 sample had significantly more participants aged 18 to 29, so we need to do a little bit more digging before making concrete conclusions there. Looking at intolerance of uncertainty, then we see very similar trends to the mental health data. In phase 1, intolerance of uncertainty was significantly higher for people aged 18 to 29, and was also higher for for females compared to males. In phase 2, the difference remained between age groups, but was no longer significant between males and females. We can see that intolerance of uncertainty peaked in February 2021 in the middle of the third lockdown, which coincided with the highest scores for mental health symptoms and loneliness. So then in terms of loneliness, people aged 18 to 29 reported significantly higher levels of loneliness throughout phase 1 and phase 2 than people aged 30 and above. The difference was not significant during survey 1, suggesting loneliness increased for younger people throughout the pandemic. Similar to the findings on gender and mental health, the difference in loneliness disappeared and actually inverted in phase 2 of the project. The crucial takeaways from the quantitative piece of this project are that loneliness and intolerance of uncertainty were significant predictors of mental health during the pandemic, and people aged 18 to 29 reported poorer mental health and higher levels of loneliness than people aged 30 and above. The question is then why? So we asked a number of qualitative questions during phase 2 to contextualize these findings and create a more cohesive picture of loneliness during the pandemic. And then to understand its relationship with mental health. But what do I mean when I say mental health? Mental health does not refer to feeling good or feeling bad. It's recognizing how you feel and what you need in the present moment and the future. Being able to accept your experiences and to fully embrace the present moment. According to Dr. Tony Bates, the founder of Jigsaw and a clinical psychologist, there are different types of loneliness and different definitions, but it is not simply being alone. It's more like finding it hard to be with yourself. I really like this definition of it because it highlights the personal nature of feeling lonely, and it permits a clear link with mental health. If one is not comfortable in their own company, they cannot accept their own experience, nor can they embrace the present moment fully. Steve Hayes, the founder of Acceptance and Commitment Therapy, has a brilliant talk on how to overcome this self-rejection and accept yourself more in the present moment. He speaks of his own experiences of loneliness, anxiety, and depression in a jarringly open manner. But one quote which really connected loneliness and mental health for me was, "I want you here with me." Dr. Hayes wasn't referring to his friends, his family, or his dog. He was speaking about the scared child within himself, the parts of him which were filled with fear, uncertainty, sadness, and doubt. He was speaking of the need to accept how we feel, regardless of our preconceived notions of who we are or how we should feel. Our data shows that COVID-19 and the response to the outbreak evoked these kinds of emotions for a lot of people. Uncertainty was rife, and those who are most intolerant were more likely to report poor mental health and higher levels of loneliness. But there is also a sliver of beauty that comes from the data. It's not just intolerance, rejection, and fear. In survey 4 and survey 6, at the start and end of phase 2, we asked participants whether they thought the pandemic would have a lasting psychological impact on them. The response was open-ended, and people responded with some incredible stories, thoughts, and details. We then conducted an inductive thematic analysis of the data using Braun and Clark's method and extracted the following themes across both surveys. There were other themes and topics, but these were the most prominent during our initial analysis. What really stood out for me going through the data was that people reported a large amount of introspection and self-exploration during the pandemic, and many mentioned how this was almost forced upon them due to the amount of time they had. But there was also almost a tone of positivity and gratitude for having had that time to explore one's own internal workings. This was by no means the case for all participants, but we can see the percentage of responses in the self-discovery category increased from 20% in survey 4 to 28% in survey 6. Having said that, the connection between feeling lonely and mental health was just as strong as introspection and positivity. Here are some examples of the different forms of loneliness and different ways it was expressed. So there's some really powerful narratives there and some really strong emotion. And a year of isolating, locked up like a prisoner. It really hurt me. I'll put them back up at the end, but I was quite humbled reading through some of those stories people were willing to share in this format. The other powerful theme from my reading and analysis was the prominence of self-reflection and greater self-awareness. And I really like this group of quotes because I feel it captures the greater difficulty of the younger people in the sample to undergo this self-reflection and introspection. Even the length of their writing highlights the need to express this. These are full answers, not just short quotes that were given in the survey. So on the left, we have the 21-year-old male and 18-year-old female, and on the right, we have the older group, the 51-year-old, 44, and 60. Much shorter, concise explanations. And then there's also a content analysis to be done at some point. We're now conducting a thematic analysis on the impact of the pandemic on relationships, and similarly, the data presents both positive and negative impacts of the pandemic. 46% of respondents in survey 5 reported their relationship with their family had improved during the pandemic, and I think this quote at the bottom kind of captures that nicely. Homeschooling and working from home, division of household responsibilities, etc., has meant these relations have been strained in a way not experienced before. That said, more time together has been priceless. However, 42% also reported their relationship with their friends had become strained, or there was a negative change in it for various reasons, but largely due to the simple lack of in-person contact and communication. The message I've taken away so far is that it has been very challenging for many people and has forced change which nobody anticipated. But the message from this sample is that there is hope and it has not all been negative. So I will summarize with this. In our study, loneliness increased for everyone during the pandemic, but most severely among people aged 18 to 29. Loneliness was a significant predictor of mental health throughout the pandemic and had a strong relationship with intolerance of uncertainty. Loneliness is not just being alone, but more like being disconnected from yourself and uncomfortable in your own company. The pandemic forced this situation on a lot of people and required huge alterations to most people's lives. People aged 18 to 29 have had less time to develop an understanding of their internal workings and have to sit with themselves, particularly the parts of themselves they don't like as much. I would suggest that the pandemic forced atypically high levels of introspection and self-reflection for many younger people. This can be seen in the volume of people who are bored and engaging in introspection and self-discovery, and the difference in those length of quotes. Despite the decline in mental health reported quantitatively in this sample, there is a strong tone of hope and anticipation in the future from the qualitative data. So that's everything from me. If you'd like more information about the project, feel free to contact me at the email address on screen or message me on Twitter, and thanks a million for listening.
Can everybody see that? Perfect. So I'm Alva, and I'm going to be presenting an overview of my final year research project, which I carried out with my supervisor, Dr. Sonia Deschen. And we examined health beliefs as predictors of vaccine hesitancy and adherence to preventative behavioural measures during the COVID-19 pandemic in Ireland. So firstly, I should say that my study is a replication and extension of a study carried out in Quebec, Canada by Gowan et al., whose name I can never pronounce correctly. And they looked at socio-demographic characteristics, health beliefs, social norms, and adherence to physical distancing in Canada. So, as we know, COVID-19 requires rapid and widespread behaviour change to combat how highly infectious the virus is. And so this is largely the success of these measures is largely dependent on individuals' adherence to the preventative measures that are enforced to combat the spread of the virus. And they're also dependent, now that we have a vaccine, on individuals' acceptance of the vaccine. And health beliefs come into this because socio-cognitive models posit that various different health beliefs will lead to the adoption of certain preventative behaviors. So the health belief model, which is the model that was incorporated into my research, posits that perceived susceptibility, so the extent to which individuals perceive that they are at risk of contracting COVID, perceived severity, so the extent to which they believe that if they were to contract COVID, it would be very bad for them. The barriers to adherence, so how difficult adhering to physical distancing would be, and then the benefits. So if they perceive that there are a lot of benefits to adhering to physical distancing, like not contracting COVID-19, they'd be more likely to adhere to these behaviours. The existing research at the time that I carried out my research project was quite limited in terms of health beliefs for the self and adherence to preventative behavioural measures, which I will call PBMs from here on out to save time. There was positive associations between susceptibility and benefits for adherence, but there was quite mixed results for perceived severity and perceived barriers. In terms of health beliefs for others, socio-cognitive models don't typically include health beliefs for others. We included them in this model, in the study, because of the kind of risk that COVID-19 poses to many individuals simultaneously. And the limited research that does exist is quite mixed. For vaccine hesitancy, there was some evidence that perceived severity, but not perceived susceptibility, increased vaccine acceptance. But in terms of health beliefs for others, there's actually no reference to health beliefs for others and vaccine hesitancy in the literature. So we had 6 hypotheses based on kind of the existing research and the health belief model. The first 3 were that perceived susceptibility, perceived severity, and perceived benefits of adherence to preventative behavioural measures where the self, loved ones, and the community would be positively associated with adherence to these measures. The 4th hypothesis was that greater perceived barriers to adherence to PBMs for the self would be associated with lower adherence to PBMs. Barriers for the self, we didn't have any barriers. We didn't include barriers for loved ones or the community because you can't really perceive barriers for others. So that's why just the self is used for that one. And then we had perceived susceptibility and perceived severity for the self, loved ones, and the community for vaccine hesitancy. And the reason benefits and barriers aren't included here is because the items used in the survey were specific to adherence to the measures rather than to vaccine hesitancy. So I've just included this graph here as kind of a visual overview of the progression of the pandemic. Data collection for my research took place mid to the end of January. And as you can see, just the sheer number of cases that were being reported during that time in comparison to previous months in the pandemic when the research that I was examining for my project had been carried out. So I guess that's a unique aspect of my research, is that it was carried out during the time when we had the highest number of cases reported in Ireland. So data analysis for my study was carried out using an online questionnaire on the survey platform Qualitrix. Participants were recruited from my social media accounts, so Facebook, Instagram, and LinkedIn. Participants had to be over the age of 18 and living in Ireland. Data analysis was carried out using SPSS version 26, and linear regression was used to identify predictors of adherence to PBMs and vaccine hesitancy. For the measures included in my study, we collected data related to participants' socio-demographic characteristics, so their age, gender, essential worker status, their health risk status, and the health risk status of people living in their household. So whether or not they were at high risk for COVID-19, and if the participants themselves or a household member had received a COVID-19 diagnosis previously. Participants also rated their adherence to physical distancing over the previous two weeks on 7 items. So things like not having visitors in their home. They also rated their adherence to personal protective behaviors, things like washing your hands with soap for at least 20 seconds. And these 2 measures, adherence to physical distancing and adherence to personal protective behaviors, were averaged to provide a mean score for adherence to preventative behavioral measures. Health beliefs were also examined, obviously, and participants rated items related to the 4 health beliefs: susceptibility, severity, barriers, and benefits. 1 item looked at vaccine hesitancy. This was taken from a previous study by Lazarus et al. And the item just stated that if a safe and effective vaccine was made available to them, they would accept it. There's also previous evidence that age, gender, and essential worker status affected adherence to behaviours and measures. So these were included as covariates in the study. So there were 1,005 participants in total. 196 of these participants had incomplete data, so they were removed. There wasn't any difference between sex, age, or essential worker status between those included and excluded. 86% of participants identified as female, 41% were essential workers, 59% were obtaining or had obtained a third level qualification. The model age group was 35 to 44, and only 2% of participants were aged over 65. So looking to the results of the study, this graph and the next graph are really just for a visual overview of participant responses. So you can see that 600 or almost 75% of participants said that they often adhered to preventative behavioural measures. And similarly for vaccine acceptance, almost 600 participants of the 809 participants said that they completely agreed that if a safe and effective vaccine was made available to them, they would take it. We had 4 linear regression models, and 2 of those related to adherence to preventative measures. So both models were statistically significant, explaining 15 and 17% of the variance respectively. And when accounting for shared variance amongst the predictors, we can see that perceived severity and perceived benefits for the self were significant. And in terms of health beliefs for loved ones in the community, perceived benefits for loved ones in the community was significant, and perceived severity for the community was significant when controlling for the shared variance in the predictors. There's also 2 models for vaccine hesitancy. Both were statistically significant and both explained 2% of the variance. Perceived susceptibility for the self was significant when controlling for the shared variance. Perceived susceptibility for the community and perceived severity for the community was also significant when controlling for the shared variance. So we can see that the community and health beliefs related to the community are quite important predictors. So our results show that the more individuals believe the virus is dangerous to them and the community, and the more they believe that adherence to PBMs will protect them from contracting the virus, the greater they adhere. Those who believe that they and their community are at risk of becoming infected, and that if infected, the virus would be severe for them, for their community, report greater willingness to accept a COVID-19 vaccine. We can also see, as I said, that the community is an important predictor. Perceived susceptibility does not really seem to be a strong predictor, which kind of contradicts the health belief model. So that would require some further research just to figure out why that finding occurred. And also we see that perceived benefits is quite a strong predictor. Limitations to the study. We used a convenience sample and participants were recruited through my social media accounts. The sample was quite heterogeneous. We had 86% of participants identifying as female, so findings might not be applicable to predominantly male samples. Only one item was used to measure each predictor variable, so proper psychometric evaluation couldn't be conducted. This can be justified in light of the novelty of COVID-19 at the time of kind of putting the study together, but probably should be rectified in future research. Vaccine hesitancy was measured using intentions, because the vaccine wasn't available to the general population at the time of data collection. But as we know, intentions are a poor predictor of actual behavior, so that should probably, now that the vaccine is available to a wider audience, be examined whether or not people are actually accepting the vaccine. Implications of the study. It adds to the evolving body of knowledge surrounding COVID-19 health beliefs and behaviors. Within an Irish context, it provides a first step in identifying health belief predictors of adherence to PBMs and vaccine acceptance. And maybe most importantly, it highlights avenues for future research, which can then inform health promotion communications. I want to say for future pandemics, but hopefully there's not too many of them. A couple of recommendations for future research, most of which I've already mentioned, so including items to assess perceived benefits and perceived barriers for vaccine hesitancy. As we've seen, perceived benefits are a strong predictor of behavior, so it would be important to examine those variables. Measuring behaviors rather than intentions in relation to vaccine hesitancy, having a more diverse sample, so more male and elderly participants, using more than one item to assess predictor variables, and carrying out longitudinal research. I think it would be useful for health promotion campaigns to examine how behaviors and how health beliefs might change over the course of a pandemic. So just to conclude very quickly, the study provided an examination of the association between health beliefs, adherence to PBMs, and vaccine hesitancy during the COVID-19 pandemic. And some of the main findings were the importance of health beliefs related to the community and the benefits of adherence to PBMs, and also for the self, loved ones, and the community. So that's everything. Thank you for listening.
Hi everyone. Thanks so much for joining me today. My name is Cian Prendergast and I'm a research assistant. So today I'm presenting research I'm working on as part of a team aiming to evaluate a remote app-based intervention we developed known as the PAUSE program. So we'd also like to acknowledge that this work is funded by the Health Research Board in cooperation with the Irish Research Council as part of the Rapid Response COVID-19 funding. I'd also like to draw your attention as well just to the research team and their affiliations, in addition to the principal investigator, so Professors Louise McHugh and Alan Carr and Dr. Tom Burke, who were mentioned on the previous slide, which you can see listed there at the bottom of the slide, just to acknowledge their contributions to the current study as well. So to give you a brief outline of what I'll be talking to you all about today, I'll talk about some of the literature that informed the development of this intervention in response to COVID-19. I'll also give a description of the study protocol, including what the design of the study is and who the participants we will be recruiting. I'll also give a description of the intervention itself. So just to note that we are currently still developing the app and have not yet started data collection. And then finally, I'll comment on what some of the potential uses of the intervention may be in the future. So the current literature tells us that the psychological impact of a pandemic or epidemic can negatively impact people in many areas of their lives and have lasting effects. So for instance, a number of mental health disorders have been prevalent following early cases of COVID-19 infection, including depression, psychosis, post-traumatic stress disorder, insomnia, and more. The most common symptoms research has reported related to a pandemic or epidemic include low mood, irritability, anxiety, and elevated general distress. So these negative mental health outcomes are not only limited to those who've been infected, but also to those who've been directly or indirectly exposed to the virus. So research specific then to COVID-19 has reported that there have been significant increases in levels of depression, stress, and anxiety. So as we all know, COVID-19 has caused many disruptions to mental health services and how they're operating. It's limited people's access to face-to-face interventions and increased waiting times, on top of the fact that the need for access to psychology services has also increased in response to COVID-19. So for this reason, there's a clear need for a remote psychological intervention to meet the public's needs in a safe and reliable way. So this brings us then to the current study. So we've adopted a pre-post repeated measures mixed methods design. 3 different assessment time points will take place approximately 20 minutes to complete. So baseline data will be collected at time 1, with immediate follow-up data once they've completed the intervention at time 2, and then 6 weeks post-intervention at time 3. Participants will be randomized into either a control or experimental group. So one group will have access to the intervention tool immediately once completing the baseline measures at time 1. And a second group will have access to the intervention 6 weeks after the first group at time 2. Participants will consist of adults in the general public in Ireland, and we're aiming to collect data from at least 52 cases with 26 participants in each group. We have consent to contact participants as well from a previous study conducted by Burke et al. In 2020, which we expect to meet our sampling needs, but we can also recruit through different media and networking platforms if needed. So we will gather time 1, 2, and 3 data using Qualtrics online. And the primary outcomes that we're going to be looking at include well-being, depression, anxiety, stress, and trauma symptoms. Then the secondary outcomes include illness perception, coping, and post-traumatic growth. And engagement with the intervention itself is going to be tracked through the app. And then the intervention uses an evidence-based integrative framework, which is largely based off positive psychology. However, also utilizes other models and frameworks, including CBT, ACT, and mindfulness. The intervention will consist of time-released modules over 6 weeks, and each module should take about 45 minutes to an hour to complete. And the intervention attempts to mimic clinical practice as much as possible with this kind of weekly schedule and the length of each module, even though it is meant to be used at participants' own ease and when it kind of suits them. So the PAUSE program, or the Psychology and You Self-Enhancement program, will look something like this. Each module is adapted from Alan Carr's Positive Psychology and You, a self-development guidebook. So you can see the intervention looks at a number of topics and aims to teach users a number of strategies. So these look at things such as physical exercise and meditation that you can see in module 2, to other skills and topics like cognitive and problem-solving strategies that you can see in module 4, for example. Each module then aims to strike a balance between psychoeducation and teaching new skills specific to each topic. And the hope is that this intervention will be beneficial to anyone who uses it. The PAUSE program encourages participants to try out all of the strategies it teaches in an attempt to find a number of strategies that might fit their needs and be useful to them even after the intervention is completed. So just to note that the app was designed to be self-directed in the same way that Alan Carr's book was written, so that it can be used reliably without a clinician present. We felt this integrative framework as well would be especially useful to use for the PAUSE program, as it not only looks at alleviating people's distress during COVID-19, but also helping them to find ways to thrive and increase well-being. Participants will be guided through each module through a narrated video, and they'll be able to opt in to receive reminders, prompts, notifications through their phone. This is going to help them then to facilitate completion of different homework-based tasks and reliable continued engagement. So as I mentioned before as well, we're currently in the process of developing this app and hoping to start data collection in the coming months. So assuming that the PAUSE program produces these positive outcomes that we expect, this could potentially be a really useful tool in a number of areas. So for instance, it may be useful for supporting clients who are on long wait lists that can't get access to a psychologist as soon as they would like. COVID-19 has put a lot of pressure on mental health services, as I mentioned earlier, not just because of the increased demand for these services, but also the massive delays it's caused with accessing services, which is adding to an already present concern of long waiting lists. Additionally, it may be useful in supporting families and caregivers of those with high needs and around-the-clock care. So a compelling body of evidence as well suggests that many caregivers experience negative psychological effects, and some caregivers are at higher risk than others, especially those who spend long hours caring for older adults with advanced dementia, for example. Caregivers should have access as well to high-quality evidence-based interventions designed to mitigate or prevent these adverse health effects. And then finally, this could be a really useful tool to be dispersed within communities and community services. So as the PAUSE program is designed to be accessed remotely by the general public, it's expected that this could be a really useful preventative tool targeting people who have not yet accessed mental health services, but feel that they could benefit from psychological support. So thanks very much for listening, and I'll be happy to take any questions then at the end.
Check, can everyone see that? Perfect. Yeah, so welcome everyone to my project that was part of my undergraduate degree. So it was presented as part of the BA International in Psychology this year in University College Dublin. It's titled Not So Healthy After All, The Role of Health Tracking Apps in Eating Disorder Symptomatology, and was supervised by Dr. Kathy Looney. And it really took place in the context of the COVID-19 pandemic, kind of unintentionally, obviously, but hopefully can offer some insights into this area of research during the COVID-19 pandemic. So firstly, eating disorders, they're complex psychological disorders that affect every aspect of a person's functioning, and they include extreme behaviors and cognitions relating to food and to exercise, and really have a large impact on the person's well-being, their physical and their emotional well-being. So recently there's been a prevalence of 7.8% in the 2013 to 2018 period, and this is growing. So there's really a need to look at the factors that might be contributing to this trend. So particularly for young females, there's sociocultural standards of beauty that really dictate that women should have this ideal lean body shape. And this is has quite a big impact that is known as normative discontent with your shape or body image. Alongside this, there's been an increase in some health tracking apps, which are apps that allow users to track kind of any behaviors in relation to their health. And these include Fitbit, Strava, and MyFitnessPal. And commonly tracked health indicators include weight, calorie intake, and exercise. But really, there could be a potentially dangerous side to these apps because they can encourage people to fixate on these numbers and really incorporate maladaptive eating exercise practices to keep these numbers perfect. And then alongside this, there's been the impact of COVID-19, which has been associated with increased levels of psychological stress and changes in eating and exercise behaviours. As well as this, there's a 66% increase in hospital admissions for EDs during the COVID-19 pandemic in Ireland. So I suppose a bit of the previous research in this particular area of health tracking apps and eating disorder symptomatology, there's been association between MyFitnessPal usage and heightened ED symptomatology, whereby MyFitnessPal users demonstrate significantly higher ED symptomatology than non-MyFitnessPal non-users. As well as this, most studies have just looked at MyFitnessPal and particularly calorie tracking. However, some studies have found that it is exercise tracking that is uniquely associated with overall heightened ED symptom severity, although calorie tracking was also implicated in the subscales of the measure used in those studies. As well as this, although studies are more often conducted in a female population due to the higher prevalence of EDs in a female population, there's also evidence that male MyFitnessPal users demonstrate higher levels of ED symptomatology than male non-users. So really, it just kind of shows that there's a need to incorporate both males and females in research in this area. And then the last kind of thing that is like most of the studies, all except for one, assessed health tracking app use with a dichotomous yes or no question. So they just asked if they were users or non-users. However, a study by McCaig et al. And the kind of qualitative insights into this area revealed that engagement is much more complex than this and should be assessed using more of a multifaceted measure. So stemming from here, this study took place in the context of the COVID-19 pandemic, and the hypotheses were as follows. Hypothesis 1, that there will be a significant positive correlation between app engagement and ED symptomatology. Hypothesis 2, that there will be an interaction effect between gender and app engagement group in terms of ED symptomatology, with the female high engagement group demonstrating significantly higher levels of ED symptomatology than the others. And hypothesis 3, that there will be significant differences in ED symptomatology according to the function that the app used or that the participants used the app for. And that was a non-directional hypothesis, as there was conflicting findings in the literature. So the study was cross-sectional nature, and it used a complex design to investigate the research questions. And the participants were recruited using online social media, using the advertisement on screen there. And then there were 183 participants recruited, all were over 18, and all were health tracking app users. There were more females than males, with 71.6% identifying as female, and a mean age of 22.49 years. The majority of the participants were white and were residing in Ireland. And the measures used in this study was the Eating Disorder Examination Questionnaire, and this is higher scores indicating higher levels of ED symptomatology. And this converges well with eating disorder examination interview, which is really regarded as the gold standard in ED assessment. And then to really overcome the limitations of previous research, I adapted the Facebook intensity scale to measure engagement with health tracking apps. And this has been adapted for numerous other social media sites, such as Twitter, LinkedIn, Instagram. And I just replaced my health tracking application, or I replaced Facebook with my health tracking application each time, and higher scores indicate higher engagement with the app. So the results of this study were that, firstly, using an EDQ global score of above 4 as the cutoff point for clinical significance, 12.6% of the sample scored in the clinically significant range, and then a further 29.5% demonstrated eating disturbances in line with Mond et al.'s threshold of above 2.3. And then the sample was dichotomized along the mean score on the FBI, and this resulted in the formation of a high engagement group as well as a low engagement group, and you can see kind of dispersion of males and females across those groups in figure 2. And a weak but significant positive correlation was observed between ED symptomatology and engagement with health tracking apps. So this supported hypothesis 1. And the descriptive statistics for the EDQ global scores, according to gender and level of app engagement, are presented in table 1, as well as the plotted mean EDQ scores according to gender and app engagement in figure 3. So the two-way ANOVA revealed no significant interaction between the gender and app engagement group, so hypothesis 2 was not supported. However, although no hypothesis was made about gender, the two-way ANOVA did reveal that females demonstrated significantly higher EDEQ global scores than males. And then finally, for hypothesis 3, there were 5 participants who did not use their app for either exercise tracking, calorie tracking, or tracking both, so they were not included. But of the participants that were included, the descriptive statistics are presented in table 2 and the plotted mean EDEQ global scores in figure 4. So the one-way non-repeated ANOVA revealed that at least 2 of the groups differed from each other in terms of their ED symptomatology, and then post-hoc comparisons revealed that it was the calorie tracking group and the tracking both group had significantly higher ED symptomatology than the exercise tracking group, respectively. And then when you looked at the calorie tracking group and the tracking both group, in terms of their ED symptomatology, there was no significant difference between those groups. So the first thing to note is that although there were some really good strengths of this study, it was not without its limitations. And the strengths included that there was the use of the well-validated and reliable scales, and it was really a particularly relevant sample of young adults, as these are the group that are most likely to use health tracking apps and are also at heightened risk for ED symptomatology. And the limitations include that there could be no causation inferred from the findings, and as well as this, there is quite a big gender imbalance, which might have played a role in the findings, as I'll discuss in the next slide. However, it is important to note that if I had kind of balanced the gender in this sample, it mightn't have been as representative of the population as it is females who generally use health tracking apps more than males. So really, what do the findings mean? The mean EDQ global scores for the sample were cautiously observed to be higher than those observed in the general population norms. So this might suggest that this study converges with previous findings of app users having heightened ED symptomatology compared to non-users. And this interpretation is supported by a higher prevalence in this sample as 12.6 of a higher prevalence of clinically significant scores, as 12.6% scored in the clinically significant range, and the prevalence is 7.8 in the general population. Furthermore, the results of the study diverged from the aforementioned studies that had found exercise tracking is uniquely associated with heightened ED symptomatology, as in this study it appears that it was the calorie tracking that might potentially be driving up the scores in the tracking both group, and really identified calorie tracking as a potential kind of danger to these health tracking applications. And then furthermore, when looking at the lack of the interaction effect, it might have been due to the gender imbalance, as there was less males across the high engagement and the low engagement group than females, so there's a reduced power. Another kind of option that it might have been that the scores in the FBI really represented more of a moderately low and a moderately high group, rather than an extreme low and extreme high group, as I think it could have potentially been like we were looking for people who might have the app and mightn't engage in it that much, but maybe these users thought that they shouldn't participate in the study, as being a health tracking app user was a requirement for taking part. So to detect more like the nuances between the groups, it might be better to include a no engagement group in the future. And then I suppose coming back to kind of the whole theme of the conference is, what about COVID-19? So the study took place during the pandemic. The data was collected in February and March of this year. And this was observed alongside a 70% increase in media device usage. So this was really in light of strict restrictions on mobility and contact with others. Also a time of heightened distress and anxiety. So really there's a need to kind of replicate these findings and see, do they still exist in or after COVID, and hopefully whenever everything goes back to kind of normal, or the new normal and everything like that. So I suppose the last thing to look at is, what can we really take from this study and what are the key implications? So the use of health tracking apps is not inherently negative. They can definitely be used in a positive manner. However, it is important to note that there might be a potential role for these apps in facilitating maladaptive eating and exercise behaviours, particularly for females and for those who use the health tracking apps to monitor their calorie intake. The findings do suggest that it might be advantageous to inform people about these potential dangers of quantifying their everyday behaviours. And also it might be beneficial for clinicians to look at the patient's use of health tracking apps when assessing for ED behaviours and deciding on treatment for disordered eating patterns. And again, future research should aim to investigate these findings further, and possibly in a post-COVID-19 pandemic world, and also using an experimental design to see if there's any causation that can be inferred from the findings. And if you're interested in doing any more reading on this area, there's a list of suggested reading. And just a little thank you all for listening, and I really hope you enjoy the rest of the conference. It's been really, really interesting so far.